Welcome to this comprehensive guide on jugular venous pulse, presented by HeartbeatsZ. This video is designed for medical professionals seeking an in-depth understanding of JVP. In this video, we will cover the basics of JVP, pressure measurement, changes with maneuvers, anatomy comparison with carotid pulse, patient positioning, measurement techniques, causes of elevated JVP, wave patterns, and clinical implications. The jugular venous pulse reflects the oscillating top of the vertical column of blood in the right internal jugular vein, closely related to right heart hemodynamics. Anatomically, the internal jugular vein runs between the two heads of the sternocleidomastoid muscle, making it preferable over the external jugular vein for assessing right atrial pressure. The right internal jugular vein has a straight course to the superior vena cava and right atrium, unlike the left internal jugular vein, which may be compressed by a dilated aorta or aneurysm. Comparing the jugular venous pulse with the carotid pulse, the JVP is superficial and lateral in the neck, with 2 peaks and 2 troughs per cardiac cycle. Proper patient positioning is crucial for accurate JVP measurement. The patient should lie comfortably with the trunk inclined at an angle and the neck and trunk aligned. To measure JVP, the lower point of the measuring scale is conventionally kept at the sternal angle, but using the clavicular end can provide more accurate readings. Elevated JVP can indicate increased right ventricular pressure, reduced compliance, or conditions like RV infarction, RV failure, and SVC obstruction. The classic peripheral venous collapse technique and its modifications, such as anthem sign and Risk-Haller sign, are used to assess central venous pressure. Changes in JVP with maneuvers, such as positional change, respiratory change, and abdominojugular reflux, provide valuable diagnostic information. Respiratory changes in JVP, including Kussmaul's sign, are significant in conditions like restrictive cardiomyopathy, constrictive pericarditis, and heart failure with reduced ejection fraction. The hepatojugular reflux maneuver is used to assess latent right ventricular failure and silent tricuspid regurgitation by applying gentle pressure to the abdomen. Positive abdominojugular reflux indicates elevated central venous pressure or pulmonary artery wedge pressure, common in conditions like RV failure, LV failure, and tricuspid regurgitation. Trapezoidal and square wave responses to abdominal pressure provide insights into abnormal hemodynamic responses and underlying cardiac conditions. The timing of waves in relation to the carotid pulse and jugular venous pulse is crucial for accurate diagnosis and understanding of cardiac cycles. Jugular venous pulse, heart sounds, carotid pulse, and ECG tracings are essential components for evaluating cardiac function and diagnosing various conditions. The A wave, X descent, and X descent in the JVP waveform correspond to atrial systole and right atrial relaxation, providing insights into atrial function. The C wave and V wave in the JVP waveform are associated with isovolumic systole and ventricular filling, respectively, reflecting right heart dynamics. The Y descent in the JVP waveform represents diastolic collapse wave and tricuspid valve opening, crucial for understanding right atrial emptying. Thank you for watching this detailed guide on jugular venous pulse. We hope this video has enhanced your understanding and clinical practice.